Welcome back to the Deep Dive. Today, we are walking through the double doors of the emergency department. We're going straight past the waiting room, heading right for the trauma bay.
Right into the chaos.
Exactly. And we've pulled a massive stack of papers, clinical guidelines, surgical protocols, on a topic that feels like probably the highest stakes poker game in emergency medicine.
I think that's a perfect way to describe it.
We are talking about liver trauma.
Yeah, it really is a high-stakes environment. It's a topic that, it sits right at that intersection of just brute force physics. We're talking car crashes, falls, violence, and this incredibly delicate split-second physiological decision-making.
Right.
And what's so fascinating about the liver, especially in a trauma setting, is that it's not just an organ. It's a potential time bomb.
That is exactly the vibe I got reading through these case studies. It feels like you're reading a thriller script. But before we get into the blood and guts, literally, let's orient ourselves a bit.
Yeah.
Why the liver? I mean, out of all the things that can break or burst in the human body, why are we dedicating an entire deep dive to this one organ?
There are two big reasons, really. The first is just geography.
Mhm.
The liver is the largest internal organ you have. It sits right there, tucked under the right rib cage, and it takes up a massive amount of real estate in your upper abdomen.
It's just big.
It's huge. It's heavy, it's solid, and it's incredibly vascular. It's just full of blood. And the second reason is its vulnerability.
Okay.
In what we call blunt abdominal trauma, which we'll get into, the liver is the second most commonly injured organ. It's right after the spleen.
Ah, okay. I've heard about spleen injuries in sports and things.
Exactly. But here's the difference. Unlike the spleen, which, if push comes to shove, you can often live without it, the liver is absolutely essential. You need it to survive. Period.
So it's big, it's in the line of fire, and it's vital. That is a really bad combination in a car crash.
A terrible combination.
Now, looking at the history here in these papers, the way we handle this has changed completely.
Right.
This isn't the same medicine that was being practiced, say, 30 years ago.
Oh, it is night and day. And that, I think, is the central tension of this whole deep dive. It's what we're calling the big shift.
The big shift.
Yeah. If you went to a trauma center in, say, 1985 with a liver injury, you were almost certainly getting a massive scar. The philosophy back then was routine surgery.
Let's open them up.
Open everyone up. If it's broken, you cut the patient open and you fix it. It was a very mechanical approach.
Which seems intuitive, doesn't it? I mean, if something is bleeding inside of me, my first thought is I want you to go in there and sew it up.
It does feel intuitive. It feels like the right thing to do. But what the data showed us over years and years was that we were actually hurting people by trying to fix them too aggressively.
Really? How?
We were causing more complications, more bleeding sometimes. So over the last few decades, we've moved to what we call selective non-operative management.
Selective non-operative management. That sounds like a very fancy way of saying wait and see.
It is, in a way, but it's an active, hypervigilant kind of waiting. And this really brings us to the core mission statement of our discussion today.
Okay.
If you take one thing away from our chat, let it be this aha moment. The decision to operate is rarely based on how scary the liver looks in a picture or on a CT scan.
So not based on the image.
Almost never. It is based almost entirely on the patient's stability, on their physiology, their blood pressure, their heart rate.
That is the headline right there.
Yeah.
So you're telling me you can have a liver that looks like ground beef on a scan, just completely shattered.
A grade 5 injury,
Yeah.
Looks horrific.
But if that patient's blood pressure is holding steady, we might just keep the scalpel in the drawer.
We will almost certainly keep the scalpel in the drawer.
Exactly. We treat the physiology, not the photograph. It's a wild concept when you first hear it, that doing nothing surgical is often the hardest, but also the best thing you can do. It's incredible. So here's our roadmap for the next hour or so. We're going to break down the mechanism, how exactly the liver gets wrecked in the first place.
Mm-hmm.
We'll look at the golden rule of the primary survey, which is the survival protocol every doctor has to memorize. We're going to dissect the decision matrix, specifically that battle between the FAST scan and the CT scan.
The big fork in the road.
Right. And finally, we'll get into the specific traps that even veteran doctors can fall into when the pressure's on.
It's a journey from the asphalt of the car crash all the way to the ICU bed and hopefully back home again.
Let's start at the scene of the accident then. Section 1, the mechanism of injury. My first thought is I always assumed the ribs were there to protect the liver. Doesn't the rib cage act like, armor?
It does, but it's a double-edged sword, sometimes literally.
Oh.
The ribs can definitely protect against minor bumps, for sure. But in high-energy impacts, like a serious car crash, broken ribs can actually become daggers. They can puncture the liver.
Right.
But more broadly, when we talk about trauma, we divide it into two main buckets: blunt trauma and penetrating trauma.
And the sources are pretty clear that blunt trauma is the heavyweight champion here.
By a landslide. In civilian practice, this accounts for the vast, vast majority of cases. Think about the physics of a car crash for a second.
Okay.
You're moving at 60 miles per hour. You hit a wall. The car stops instantly. Your body stops against the seatbelt. But your liver, it has mass about 1.5 kilograms, 3 pounds.
It has momentum.
It has inertia. It wants to keep moving forward.
So it's literally splashing against the inside of your rib cage.
It's even worse than that. The liver is sort of suspended in the abdomen by these things called ligaments. In that moment of rapid deceleration, the liver can shear right off those attachments. The ligaments just tear.
Wow.
Or it gets crushed. It gets compressed between the spinal column in the back and the steering wheel, or the seatbelt in the front. So it's this combination of compression and shearing injury. It can essentially burst from the inside out.
That is such a visceral image. It's not just a bruise. It's a structural failure because of physics.
Precisely. And that's just car accidents. The other big one in the blunt category is falls from a height. The impact sends a shock wave through the torso that can just rupture the organ.
And the other bucket you mentioned is penetrating trauma.
Yeah.
Which is, I assume, exactly what it sounds like.
Yep. Stab wounds, gunshot wounds, shrapnel from an explosion. These are less common generally in most places, but they're surgically distinct because they break the skin barrier and enter the cavity directly.
A whole different problem.
The damage can be more localized, but it can also be incredibly severe depending on the trajectory of the bullet or the knife. But for the sake of the exam pearl here, for anyone listening who's studying for boards, if you are betting on probabilities in the ER, you assume it's blunt trauma.
Got it. Okay, so the accident has happened. The patient has arrived. The paramedics have wheeled them through the doors. They've been pulled out of a wrecked sedan. What are we looking at clinically? What do you see?
Pain? A lot of it. And specifically, right upper quadrant pain. That's the neighborhood where the liver lives.
Okay.
The belly might be what we call distended. It looks bloated or tight, and that's a bad sign. That usually means blood is filling up the abdominal cavity.
Not good.
Not good at all. But there is a specific kind of weird symptom I want to highlight because it trips people up all the time.
Is this the shoulder pain thing that was in the notes? That seems so strange.
Yes, care sign, or more generally, referred pain. So a patient comes in, they have a clear steering wheel mark on their belly, but they are screaming that their right shoulder hurts.
And a rookie in the ER might think, oh, they must have hit their shoulder against the door during the crash.
Exactly. And they might waste precious time sending them for a shoulder x-ray, completely missing the life-threatening internal bleeding. But a pro knows the anatomy.
Okay, so connect the dots for us. What's the link?
The liver sits right up under the diaphragm. That's the big sheet of muscle that helps you breathe. If the liver bleeds, that blood pools and irritates the underside of the diaphragm.
Okay, so irritated diaphragm. How does that translate to the shoulder?
It all comes down to the body's wiring. The phrenic nerve, which is the nerve that controls the diaphragm, it originates from the C3, C4, and C5 levels of the spine up in your neck.
Right.
And those are the exact same spinal levels that supply a sensation to the skin over your shoulder.
So the brain gets its wires crossed. It can't tell where the signal is coming from.
The brain receives a distress signal from the C4 nerve root. It's not really used to feeling pain from the diaphragm. That's a rare event. But it feels pain from the shoulder all the time. So it interprets the signal as coming from the more common location.
That is such a cool piece of biological trivia. It's like a glitch in the body's dashboard warning system.
It is. So if you see shoulder pain in a patient with belly trauma, that is a liver injury until you prove it's not.
Okay, let's talk about the really scary stuff, the red flags. The source material talks a lot about hypovolemic shock.
This is the game changer. This is what kills people. Hypovolemic just means low volume. Hypovolemic.
Low blood volume.
Right. The patient is bleeding out internally. The tank is running empty. And you need to be able to recognize this from across the room, usually before you even touch the patient.
So what are the big indicators? What are the numbers flashing on the monitor that make everyone in the room stop what they're doing?
There are 3 big ones mentioned in all our data. First, hypotension, low blood pressure. The pressure drops because the pipes are effectively empty.
Makes sense.
Second, tachycardia, a fast heart rate. The heart rate spikes to 120, 130, 140 beats per minute. The heart is just frantically pumping, trying to circulate what little blood is left to the vital organs like the brain and the kidneys.
It's working overtime. And the third one,
A falling hematocrit. Now, that's a lab value. It takes a little time to get back, but it measures the percentage of red blood cells in the blood. If that number is dropping on sequential checks, you know you are actively leaking blood somewhere.
and this all leads up to the golden rule of shock that was bolded and underlined in the outline.
Yes. And if you're a student, you should tattoo this on your brain. Shock after abdominal trauma is hemorrhagic until proven otherwise.
So in plain English, that means don't go looking for other more complicated reasons for the low blood pressure.
Exactly right. Don't say, oh, maybe he's just anxious, or maybe it's a head injury causing the weird heart rate. No, stop. If they were hit in the gut and their pressure is low, they are bleeding to death. If you waste time assuming anything else, you lose the window to save them.
That sense of urgency, that discipline, it sets the stage perfectly for Section 2, the primary survey. Because my instinct, and I assume the instinct of anyone who's ever watched a medical drama, is the liver is bleeding, fix the liver, put pressure on it.
And that very logical instinct is the major exam trap. It is the single biggest mistake that can kill patients in this scenario.
How?
Yeah.
Why? How can focusing on the most obvious injury be a mistake?
Because of the ABCs. It's that simple. In trauma, we follow the Advanced Trauma Life Support, or ATLS, protocol. It is a rigid, unbending hierarchy, A, B, C, D, E.
And it's not a suggestion.
It is a mandate. A is for airway, B is for breathing, C is for circulation.
But if the liver is gushing blood, isn't that C, circulation, the biggest problem by far?
It is a huge problem. It's the problem that's going to kill them in the next hour. But think about it this way. You can have all the blood in the world inside your veins, but if oxygen isn't getting into that blood because the airway is blocked by, say, their tongue or some blood,
Then the blood is useless.
it's useless. The patient will die of hypoxia in 3 minutes. A brain without oxygen dies much, much faster than a body losing blood.
So you have to put on blinders, in a way. You have to ignore the very obvious dramatic injury.
You have to have the discipline to ignore the screaming belly injury for 30 seconds while you secure the airway. You have to
Right.
put a tube in, and notice the little caveat in the notes. Airway with cervical spine protection.
Right, because in a car crash, they could easily have a broken neck as well.
Precisely. And if you're not thinking and you just yank their head back to open the airway like you would in a normal cardiac arrest, you could sever their spinal cord, paralyze them for life.
Wow.
You have to stabilize the neck, secure the airway, check the breathing, make sure the chest is rising and falling. Only then, only when you are 100% sure oxygen is entering the system, do you move to C, circulation.
And C is finally where we get to address the liver bleed.
Correct. C is where we start pumping in IV fluids, where we hang blood products, and where we start aggressively looking for the source of the hemorrhage. But the discipline of doing A and B first is absolutely non-negotiable.
It sounds so strictly logical when you lay it out. But I have to imagine it's incredibly hard to do in the heat of the moment when there's chaos and alarms and, blood everywhere.
It takes massive amounts of training and discipline. It's about fighting your own adrenaline, fighting the urge to look at the loudest injury in the room.
Okay, so we've done it. We've cleared A and B. We're at C. We know they're in shock. We know they're bleeding. Now we need to know what's going on inside the abdomen. This brings us to Section 3, the decision matrix. This really seems to be the pivot point where the whole path diverges.
This is absolutely the fork in the road. The decision you make in the next 5 minutes determines if the patient lives or dies, and the entire decision hinges on one single concept: hemodynamic stability.
Let's really drill into this. We have 2 scenarios in the outline. Let's start with Scenario A, the unstable patient.
Okay, scenario A. This is the patient who is actively crashing. Their blood pressure is 70/40 and dropping. Their heart rate is 140. They're pale, they're sweaty, they're barely responsive. They are hemodynamically unstable.
In this scenario, the source material says the CT scanner is basically forbidden. But my question is, isn't a CT scan the best way to see the injury? Why wouldn't we want the best possible picture?
It provides the best pictures, yes, without a doubt. But Clinically, for an unstable patient, we call the CT scanner the tunnel of death.
The tunnel of death. That is incredibly ominous.
It is. But think about the logistics. The CT scanner is almost never in the trauma bay. It's usually down the hall or in the basement of the hospital. So you have to pack up this critically ill patient, put them on a little transport monitor, and wheel them away from all your resources, away from the blood bank, away from the surgeons.
They're isolated.
You're isolated. And while they're in the scanner, they are completely inaccessible. They're inside a plastic donut. If their heart stops, if they code while they are inside that machine, you cannot do CPR. You can't get to their chest. You can't operate. You have essentially trapped a dying patient in a plastic tube away from any possible help.
That is a terrifying image. So if you can't scan them, how do you see inside? You can't just be guessing.
We use the FAST scan, the
Yeah.
focused assessment with sonography and trauma.
That's the little bedside ultrasound machine.
Correct. It's a portable machine. We roll it right up to the bedside in the trauma bay. The patient does not move an inch. And we are not looking for high-definition detail. We aren't looking for a pretty picture of the liver lobes or to grade the injury.
What are you looking for?
We are looking for one thing and one thing only: black stripes.
Blind stripe.
On an ultrasound, fluid looks black. And we look at very specific spots in the belly, mainly a place called Morrison's pouch. That's the potential space between the liver and the right kidney. It's the most dependent part of the upper abdomen.
So blood pools there?
Blood pools there first. If we put the probe there and we see a black stripe of fluid, that's blood. Game over.
So unstable patient plus a positive fast scan showing fluid equals.
Surgery. Immediately to the operating room. We do not pass go. We do not collect $200. We don't need to know if it's a grade 3 or a grade 4 injury. All we need to know is the patient is unstable and the belly is full of blood. That is enough information to open them up. The goal is to stop the dying, not to get a perfect diagnosis.
So clear cut. Okay, now let's flip the coin. Scenario B.
The stable patient.
All right, scenario B. The patient was in a nasty crash, but their blood pressure is 120/80. Their heart rate is normal, maybe a little fast. They're awake, they're alert, they're talking to you. They are hemodynamically stable.
For this patient, can we use the tunnel of death? Yes, because for them, it's not a tunnel of death. For them, the CT scanner is the investigation of choice. It's the gold standard. We send them for a contrast-enhanced CT scan.
What does the CT give us that the quick and dirty ultrasound didn't?
Everything. Clarity, precision, a roadmap. The ultrasound is like using a flashlight in a dark room. The CT scan is like turning on the stadium lights.
That's a great analogy.
It allows us to grade the injury accurately using the official AAST scale. It shows us exactly where the laceration is, how deep it goes, if there's a hematoma under the capsule, and crucially, if the bile ducts might be involved.
And there's something specific mentioned in the sources about seeing active bleeding on a CT scan, right? They called it a blush.
Yes, this is a critical finding. So we inject contrast dye into the patient's veins just before the scan. It's a dye that shows up bright white on the X-ray images.
Okay.
If we see a bright white pool of that dye spreading out, leaking from a vessel in the liver tissue on the scan, we call that a contrast blush. It means there is active, ongoing, spurting bleeding from an artery at that exact spot.
And if you see that blush, but the patient is still stable, do you then rush them to surgery to fix it?
And not necessarily. And this is where modern technology has really changed the game in the last 15, 20 years. If we see a blush in a stable patient, we have another amazing tool called angioembolization.
That sounds very high-tech. Break that down for us. What is that?
Think of it like plumbing from the inside. Instead of cutting the belly open to get to the liver, an interventional radiologist goes to work.
Okay.
They insert a tiny catheter, like a thin piece of spaghetti, into a big artery in the patient's groin. Then, watching on a live X-ray screen, they thread that tiny tube all the way up the aorta into the specific arteries that feed the liver until they reach the exact little branch that's leaking.
That's incredible precision. And then what?
And then, through that tiny tube, they release microscopic metal coils, or a kind of medical-grade glue, directly into that vessel. They essentially plug the leak from the inside.
That is absolutely incredible.
Yeah.
So they stop the bleeding completely without the massive trauma of an open surgery.
Exactly. It preserves the patient's physiology. It avoids the huge stress of a laparotomy. It's a fantastic, elegant tool for the stable patient who has evidence of active bleeding.
This whole idea of grading the injury on a CT scan, that leads us right into section 4. Grading versus reality. Because I was looking at these liver injury grades from I to VI,
Yeah.
and it gets pretty gnarly at the top end.
Oh, it does. The American Association for the Surgery of Trauma, the AAST, has this grading scale. A grade 1 is basically a small bruise, a subcapsular hematoma.
Minor league.
Right. And it goes all the way up to a grade 6, which is a hepatic avulsion. That means the liver has been completely torn off the vena cava, the main vein going back to the heart. That is an almost universally fatal injury.
So here's the assumption that I would make, and I think any layperson would make. Grade 1 and 2, okay, we can watch those. Grade 4 and V, those are catastrophic injuries. We have to operate. Big injury equals big surgery.
And that very logical, very intuitive assumption is the single biggest trap for medical students and junior doctors. It makes sense, but it is fundamentally wrong.
Break it down for us. Why is that wrong?
Because the core insight of modern trauma care is this, and we're going to keep coming back to it. Injury grade does not dictate surgery.
Wow.
I have personally managed patients with grade 4 injuries, massive, deep lacerations through multiple lobes of the liver completely without surgery. And on the flip side, I've seen grade 2 injuries in unstable patients that required an emergency trip to the OR.
So it always circles back to that aha moment you mentioned at the top.
It does. It is all about the stability. Think about the anatomy for a second. The liver is wrapped in a tough, fibrous casing called Glissen's capsule. It's like a tight skin or a natural pressure suit.
Okay, like a sausage casing.
It's a decent analogy, yeah.
Yeah.
So if the liver tissue inside cracks, but that capsule stays more or less intact, or if the bleeding is sort of contained by the pressure of the surrounding organs, the blood has nowhere to go.
Right.
The pressure builds up inside that contained space, and that pressure itself stops the bleeding. It's a mechanism called natural tamponade.
So the body literally puts its own thumb on the wound. It contains itself.
Exactly. Now, imagine you're a surgeon. You see a scary-looking grade 4 injury on the CT scan. You panic a little. You rush this stable patient to the operating room. You cut open the abdomen. What's the first thing that happens?
Yeah, you release all that built-up pressure.
You pop the cork. You slice open Glissen's capsule. You release the natural tamponade that was holding everything in check. And suddenly, a stable patient with a contained, controlled bleed starts gushing blood all over your table.
Oh, no.
You have single-handedly turned a stable situation into an unstable, life-threatening one by trying to fix the picture on the scan.
That is profound.
Yeah.
It's about having the wisdom and the restraint to respect the body's own damage control mechanisms.
Precisely. And that is why we say over and over, treat the physiology, not the anatomy. Treat the patient, not the scan.
This leads us seamlessly into Section 5, the management strategies, or, as the outline puts it, to cut or not to cut. And the source material is emphatic that non-operative management is now the standard.
It is the rule for about 80% to 90% of all blunt liver trauma cases in major trauma centers today. It's the default path. But I want to be really clear about something. The term non-operative is a bit of a misnomer. It sounds passive.
Right. It sounds like we're just sitting around the nurse's station drinking coffee while we wait for the patient to heal.
Exactly. But it's actually intensive observation. It's incredibly active management. We admit these patients straight to the ICU. This is high-stress, one-on-one monitoring.
What does that look like?
We were checking their hemoglobin, their blood count every 4 to 6 hours. We are performing serial abdominal exams, meaning we are physically pressing on their belly over and over again every few hours.
What are you feeling for when you press on the belly? What's the trigger you're looking for?
We are feeling for the development of peritonitis. If the belly, which might have been soft before, suddenly goes rigid, we say it's board-like, that means the peritoneum, the lining of the abdomen, is inflamed.
And that's a red flag.
That's a huge red flag. It usually means a bowel injury, like a perforated intestine is leaking, or a serious infection is brewing. If that happens, the waiting game is over. You have to operate.
So let's talk about those triggers. When do you finally say, okay, the non-operative plan has failed. We have to go in?
There are a few absolute triggers. Number 1 is persistent hemodynamic instability. We give them a liter of IV fluids. The blood pressure comes up for a minute, then it drops right back down. We give them a unit of blood. It drops again.
They're leaking faster than you can refill them.
They're leaking faster than we can refill the tank. We can't wait anymore. That's a ticket to the OR.
Okay, what's trigger number 2?
Peritonitis, like I just mentioned.
Yeah.
If there is evidence of poop or stomach acid leaking into the belly from what we call a hollow organ injury, you have to operate. You have to go in and wash that out and fix the hole. You cannot leave that alone.
And the 3rd?
Generally speaking, Penetrating injuries, gunshots, and stab wounds are much, much more likely to need surgery than blunt injuries. The tracks are dirty, they don't heal as cleanly, and the risk of hitting other organs like the colon or the pancreas is just so high.
Got it. Now let's go into the OR. The decision has been made. We have to cut. The source material mentions a very specific concept here called damage control surgery. This sounded like something out of a submarine movie.
It's a survival mindset. It's a complete shift in philosophy. And to understand it, you have to understand what happens to a dying body on the operating table.
Okay.
In a normal elective surgery, say taking out a gallbladder, you want everything to look perfect at the end. You stitch every vessel neatly, you wash everything out, you close the skin layer by beautiful layer.
Right, you want it to be a work of art.
Exactly, but not in trauma. Not when the patient is crashing. If a patient is bleeding out on your table, they enter what we call the lethal triad of death.
The triad of death. That
Yeah.
sounds bad. What constitutes the triad?
It's acidosis, hypothermia, and coagulopathy. And it's a vicious, self-perpetuating cycle.
Oh, okay, walk me through it.
So when you lose a lot of blood, your body can't generate heat, so you get cold. That's hypothermia. When your body gets cold, the enzymes and proteins responsible for blood clotting stop working. They're very temperature sensitive, so your blood stops clotting. That's coagulopathy.
It means you bleed more, which makes you colder.
Exactly. And at the same time, when your tissues aren't getting enough oxygen from the blood, they switch to anaerobic metabolism, which produces a ton of lactic acid. That's acidosis. And a very acidic environment makes the clotting problem even worse.
It's a death spiral. Each problem feeds the next one.
It is an absolute death spiral. Once that spiral starts, it is incredibly hard to stop. If you, the surgeon, keep that patient on the operating table for 4 hours trying to do a pretty repair of the liver, they will get colder, more acidic, and their blood will completely stop clotting. They will just start oozing from every surface and bleed to death right in front of you.
So what is damage control? How do you stop that spiral?
You realize in that moment that you cannot fix the anatomy yet. You have to abort the mission and fix the physiology. So you do the absolute bare minimum to stop them from dying right now.
What does that look like?
You open the belly. You quickly identify the liver as the source of bleeding. You do not try to stitch the lacerations. You grab surgical sponges, big gauze pads called lap pads, and you pack the liver.
Packing. You mean you're literally just stuffing it with gauze?
Literally. You stuff the entire upper quadrant of the abdomen with gauze packs to physically smash the liver against the ribs and the spine. You are applying direct, brute force, mechanical pressure to stop the bleeding.
And then?
And then you leave. You get out. You do not close the fascia or the muscles. You might just staple a plastic sheet or a special vacuum device over the open belly. And you run the patient to the ICU.
Wow.
Your only goal for the next 24 hours is to fix the triad of death. You warm them up with blankets, you give them bicarbonate to correct the acid, and you transfuse massive amounts of blood, plasma, and platelets to fix the clotting.
And what about the liver and all those sponges inside?
You come back to the operating room 24 or 48 hours later, once the patient is warm and stable and their blood is clotting again. You take them back, you carefully remove the sponges, and you see if the bleeding has stopped. And usually it has. Then and only then can you do a proper repair and close up the abdomen.
That is just incredibly dramatic. You literally leave the surgery unfinished in order to save the life. It's prioritizing survival over anatomical perfection.
It absolutely is. And it's a concept that saves lives that were considered completely unsalvageable 20 or 30 years ago.
Incredible. Okay, so let's suppose they survive this. They make it through the surgery. They make it through the ICU. Section 6 tells us that we're still not out of the woods. What are the aftermath complications we need to worry about?
The liver is not just a bag of blood. It's a complex chemical factory. And one of the main things it produces is bile.
For digestion.
Right. Bile is basically a detergent. It digests fat in your food, and it is incredibly irritating to normal body tissues if it leaks out where it's not supposed to be. When you smash the liver in a crash, you don't just smash blood vessels, you smash the tiny bile ducts inside it too.
So you can get a leak?
Yes. You can get a bile leak into the abdominal cavity. This can cause severe pain and inflammation and can lead to infection down the road. Sometimes this bile will collect into a distinct walled-off pocket. We call that a biloma.
A biloma.
Yep. Think of it like a cyst, but it's filled with this toxic detergent instead of water. It usually shows up days or even weeks later. The patient goes home, thinks they're fine, then comes back to the hospital with a fever and persistent abdominal pain.
What else can go wrong?
Abscesses. Blood is basically a perfect food source for bacteria. If you have a large hematoma, a big pool of old, stagnant blood sitting in the belly, it is very, very likely to get infected over time and turn into a pus-filled abscess. That requires drainage, usually.
And there was one more strange term in the notes. Hemobilia.
Ah, yes, hemobilia. This is a rare one, but it's a classic exam question. This is a delayed complication where the initial injury creates a fistula and abnormal tunnel between a high-pressure artery inside the liver and a low-pressure bile duct right next to it.
So blood flows from the artery into the bile duct.
Exactly. And where do all the bile ducts lead?
They lead into the gut, the small intestine.
Right. So the patient might present weeks or months later with what looks like a gastrointestinal bleed. They're vomiting blood or having dark, bloody stool. But the bleeding isn't from a stomach ulcer. It's actually coming from deep inside the liver, flowing down the bile duct and into the gut. It's very tricky to diagnose if you're not thinking about it.
It really highlights that a major trauma isn't just an event, it's a condition that can last for a long, long time. You have to keep watching these patients long after the bandages are on.
Absolutely. The injury happens in a fraction of a second, but the healing and the potential for complications can take months.
We have covered a massive amount of ground today. I mean, from the physics of a seatbelt to the biochemistry of the triad of death. Let's try to bring it all home with Section 7, the rapid-fire summary.
Let's do it.
I'm going to throw a concept at you. You give me the one-sentence takeaway for our listener to lock into their brain. Ready?
Ready.
Frequency of injury.
The liver is the #2 most commonly injured organ in blunt abdominal trauma, right behind the spleen.
Most common mechanism.
Blunt trauma. Overwhelmingly. Think road traffic accidents and falls from a height.
The golden rule of shock.
Shock after abdominal trauma is hemorrhage until proven otherwise. Period.
Priority number 1 when that patient rolls into the trauma bay.
A, B, C, D, E. Airway first. Always. Don't even look at the belly until the breathing tube is in and secure.
The unstable patient protocol.
F, SAXI scan at the bedside. No CT. A positive FAST scan means a direct flight to the OR.
And the stable patient protocol.
That's who gets the contrast-enhanced CP scan. That's where you grade the injury and look for a blush.
Does the grade of the injury determine if you do surgery?
Absolutely not. Never. Hemodynamic stability determines the need for surgery, not the grade.
What is the current standard of care?
Non-operative management is the standard for the vast majority of stable patients, regardless of injury grade.
And the surgical philosophy for that crashing, dying patient?
Damage control surgery. Pack the liver, get out of the belly, and resuscitate the patient in the ICU.
Perfect. And just to hammer home those crucial exam traps one last time, because our listeners really love avoiding those common pitfalls.
Trap number 1. Do not get distracted and focus on the abdominal findings before you have stabilized the airway and breathing. You'll fail your exam and you'll fail your patient.
And trap number 2.
The big one we keep coming back to. Do not send an unstable patient to the CT scanner. Treat the patient in front of you, not your own curiosity to see a pretty picture.
Which brings us to our final synthesis. If we zoom all the way out, past all the blood and the sirens and the technical details, what's the real philosophy here? What's the big picture takeaway?
I think it's a shift from a kind of surgical arrogance to a biological humility. We used to think we could and should fix everything with a knife. Now we know that the body has this incredible innate capacity to heal even devastating injuries if we just support the physiology and get out of the way.
So stability decides management.
That is the mantra. That is the entire deep dive in 3 words.
It's a really powerful lesson. You know, we live in this age of incredible technology. We have surgical robots, high-res scanners, genetic testing. But when it comes to saving a life in the trauma bay, it seems the most important tool is still human judgment. It's knowing when not to act.
Exactly. Sometimes the best surgeon in the room is the one who has the confidence and the wisdom to keep their hands in their pockets.
And that feels like the perfect place to leave it. We'll wrap up this deep dive into liver trauma. Hopefully you never ever find yourself on a gurney in a trauma bay. But if you do, now you have a much better idea of what's happening behind the curtain.
Stay safe out there.
See you next time.